Thank you, Sri Priya. Welcome to one and all, and welcome to Brother Sajan too. As we have been telling, we have been looking into the various clinical symptoms, management issues that are involved in palliative care. As we have been always telling, nursing element forms a big part. And for that, we have an expert from the nursing specialty who is going to take us through this session. Warm welcome to Brother Sajan, who is lead for infection prevention and control in Trivandrum, Palim, India. And he has obtained his palliative care certification from Palim and has been working with Palim for the last 8 years. And he is one of the faculty members for online and on-site training. And he's an active, very involving person who makes sure that his team is happy and adequately skilled too. So with that, I hand over it to Brother Sajan to take us through this session.
Good evening to all. Thank you, Radha ma'am. Thank you for your good words. So today I would like to introduce not a new topic, but an important topic, mainly in palliative care, wound management. So I started my journey in Palim, India on 2014 itself. Around since 8 years, I am seeing so many patients with various type of wounds. So today, actually, we are going to discuss about two types of wound. So before directly going to the topic, I'm just introducing our human body having one of the largest organ, that's skin. Normal, our body is covered with skin, but due to any disease condition or maybe any artificial surgical manner, continuity of the skin is losing time only, the wound will develop. So it's by a surgical procedure or maybe due to an accident or by an injury, the wound will develop. So here we're going to discuss about two types of wounds, pressure ulcers and the fungating wounds. So first one, pressure ulcer. What do you mean by pressure ulcer? I'm expecting a reply. Pressure ulcer or pressure sore. And another name also is there for the pressure ulcer or pressure sore. You can put your answers in chat box. Another name for pressure ulcer or pressure sore. Trophic ulcer. Any other? Bed sore. Okay. Bed sore, we can say if one patient is mainly in lying position or mainly he is or she is purely bed bound, then the sore we can call it as a bed sore. Now the pressure sore, it will affect not only for the bed bound patient, whichever the position, if the patient is continuously maintaining for a while, that time the continuously pressure getting on that area. On that area, the wound that or ulcer will develop. So it can call it as a pressure ulcer. One answer I got, actually it's right, decubitus ulcer or decubitus wound. So here we just moving about the pressure ulcer. So pressure ulcer actually localized injury only. First of all, it's happening as a localized injury on the skin layer. Then it's going to underlying tissues. Then it moving to the usually over the inner or underlying layers. Mainly it happening the bony prominence area as a result of a prolonged unrelieved pressure getting on that area. If one patient is lying in one position, same position, on that area, the bony prominence from internally, it will get on pressure in between the bony prominence and the in between the mattress, the skin layers and the tissues. It will get a pressure, then only the pressure sore will develop. So while moving to pathophysiology, suppose one patient is lying in a supine position for a long time, he or she is lying in a supine position only. So some pressure prone areas is there in underlying parts. There continuously pressure getting on that area. In second picture, you can see the bony part. From bone, according to the body weight, the bone part, it will compressing the underlying muscle, tissues, and the superficial skin with the mattress. Actually, the patient is lying on the mattress only. So in between the mattress and the bone area, the underlying in between the area, muscle, tissues, and the skin getting continuously pressure. Then due to the continuous pressure getting, collapse of the underlying blood vessels. So due to the collapsing of blood vessels, blood supply, that circulation will alter. So due to the inadequate blood supply, the tissues and the cells will not get adequate nutrition or the oxygen. The supply will decrease, or maybe it will become absent. In such situation, the tissues will becoming ischemic state or the hypoxic. Then gradually the cell death or tissue damage will occur. Then only the superficially the skin layer, it will breaking down. So this is the step actually the through the pressure sore will develop. Then some of the risk factors also is there for the pressure sore. First one, if one patient is lying in supine position, in between, knowingly or unknowingly, the patient body is scratching on the bed sheet. Maybe activity is doing by the patient, or due to the unawareness, or maybe the patient changing position time in between the body parts, it's a rubbing effect will happen on the bed sheet or the linen. Such situation, the friction, that energy, due to the friction, the skin tissue will damage, maybe the chance for the peeling of the skin. Then shear. Shear means if suppose one patient is lying in supine position, in between we need to change the position. We making the patient to semi-fowler or the fowler position. Such situation, the patient will slide down. We are trying to adjust the bed sheet position. So bed sheet we need to move upward, but patient is accidentally sliding down. So in opposite direction, there is a rubbing effect will happen in between the bed sheet and the body part. So there is a shear effect will happen. So it's leading to the skin peeling. Then if one patient, suppose one patient is a paraplegic stage. Now below the hip level, the patient is having no sensory. They're having no sense. Patient is totally losing the sense below the hip level. So that part continuously keeping in one position. Patient is having, due to the non-sense, patient is cannot change the position or change in between for relieving the pressure on the lower extremities or below the hip level. So due to that condition, continuously getting the pressure on that area will cause the skin peeling. Then any physical mobility, impaired physical mobility. Patient know how to change the position, how often need to change the position, importance, everything patient know. But due to the impairment, patient is unable to change the position, or maybe nearby nobody is there to change the position. Then altered conscious level. Patient is conscious, but altered level of consciousness leads to the same condition, cannot change the position. Then, or any urinary or fecal incontinence. Continuously, the skin getting contact with the fecal matter or the urine. Continuously getting means also it will damage the skin layer. So it will lead to the peeling of the skin and the pressure sore. Then dehydration and the malnutrition. Adequate nutrition and adequate hydration level is very important for a person for maintaining the skin health. So in some condition, due to the refusal of patient or maybe due to the disease condition, the hydration level and the nutrition level also very much in decreased stage only. In such situation also, the poor skin health condition, there is a chance for easily peeling. So we need to ensure the nutritious food patient is taking or not, and the proper hydration is getting or not. We need to ensure. Then excessive body heat and excessive sweating also. It's continuously sweating means also it will damage the skin tissues. Then in elder people, mainly advanced age elder people, the skin will become very soft early, so easily chance for the peeling. So actually, these are all the common sites of the pressure ulcers in various positions: supine position and lateral position, semi-forward position, and the sitting position. Actually, here I am showing 4 positions. In supine position, back of the head or occiput area, then shoulder blade, scapular bone, lower scapular region, then lower back. If we keeping continuously the elbow hand on the mattress means the elbow region and the heel region. These are all the common pressure prone areas while if the patient is continuously in the supine position. In lateral position means right or left lateral, that concerned side, ear, then shoulder region, elbow, lateral aspect of elbow joint, outer aspect, then hip, in between the knee and the ankle joint. So these are all the common areas have the chance for the pressure ulcer development. Then semi-forward position also, and same only back of head, shoulder blade, lower back, sacrum, and the heel. So while in sitting position time also there is a chance for the mainly the patient is continuously in bed means we can call it as a bed sore, but continuously patient is sitting in a sitting position means there is continuously getting the pressure, but patient is not at all totally bed bound. So that time we can call it as a pressure sore only. So in while sitting in wheelchair time also, shoulder blade, lower back, hip means right and left both region in between the wheelchair part side, hand resting area and the hip region. In between there is a chance for getting continuously contact and getting chance for the pressure. So for skin peeling. Then sacral region, then underside and backside of the heel, continuously getting touch with the footrest of the wheelchair. So these are all the areas have the chance for getting pressure ulcer while if the patient is continuously being in a same position. So these are all the some of the pictures I'm showing an example. It's a real image only. First picture, backside of the sole region, underside of the sole, then head, the occiput area. Then this third picture is the scapular region. Then this one is the last one is the fourth one is the last toe. In side lying position, if patient is more time is lying means also this in last small toe will get the chance for get the skin peeling or pressure ulcer. Then sacral area. Then some rashes also. Not only the wound, continuously using the diaper people means also the skin rashes also can develop as a primary. Then it can become as a pressure sore. So same thing only. I'm just once again repeating this slide, but you can just go through supine position, sideline position, both in forward position and prone position also. In prone position, head in frontal region, chin region, elbow, internal aspect of the elbow joint region, chest region, reproductive organ site, mainly male patient means penis area, then knee, on the knee region only, then toes. These are all the areas getting direct continuous contact if the patient is in prone region. So these are all the sites have the chance to get these pressure ulcers. Then, while moving to the stages of wound, actually, how many stages of wounds are there in pressure sore? For any other answers? 3. Okay. Okay. Thank you. Actually, stages of wound, actually 5 stages are there. First one, this only the redness only, or the color change only, changing of the color of a normal skin. That's the first stage, but it can call it as a non-blanchable erythema. The skin layer will not drop. It only the color change only. This one is the first stage. Then this one is the second stage. Partial thickness of the skin loss, just peeling off, but shallow open ulcer only. Then first picture you can see just peeled the first layer of the skin only. There is no depth for that wound. Second one, the superficial layer is filled with the serous fluid. It's getting chance for breaking that blister at any time. So this one is the stage 2. So this one is the stage 3. Stage 3 means full thickness ulcer. Means not at a all simple peeling. After peeling, some more underlying tissues also affected. But bone or muscle or tendon will not expose. Just going to the full thickness ulcer only. Then in this stage itself, will get the chance for the tunneling, as like this. A narrow opening or the passage way we can see can extend in any direction as like a pocket formation through the soft tissue area only. So there is a no depth will be there. Some may be the tunneling at any direction. So this one is the stage 3. This one is stage 4. Stage 4 means some more depth is there. There is a chance for exposing of muscle, bone, and the tender region. So this one is the stage 4. In the stage 4, maybe highly exudate, foul smell also will be there in this stage 4. Then this one is the unstageable or stage 5. Unstageable means in unstageable or 5th stage, there is a slough is there or eschar. We can say it as a eschar. Eschar will covering on the superficially on the wound. So 2 type of eschar is there. First one, it can call it as a protective layer. In some geriatric cases, maybe in sacral region on having on sore, but superficially we can say we can see it like as a band type eschar. It's very hard and there is a no foul smell, no oozing, but we can say it as a eschar. But it is seen as like protective layer. There is no infectious sign is there. But sometimes the eschar is very soft and very foul smell having. It may be small holes in between, thick pus discharge will happen. In such situations, the eschar we need to remove. Then only we can see the wound and we can say the wound stage. Maybe it's stage 4, maybe it's stage 3. But the eschar need to remove. So the protective layer of eschar, no need to remove. In infectious stage means we need to remove the eschar by a surgical manner or according to the situation. So this one is the deep tissue pressure injury. Actually, here the superficial skin not at all peeled off, but from inside, deeply the tissues getting damaged. So while peeling off time, that wound at any extreme level, up to the 4th stage, it can go. So this one is the deep tissue pressure injury. So this one is the non-blanchable only, skin not at all breakdown. Now it's a maroon or purple color discoloration only. Actually, it's mainly happen prolonged pressure or shear forces continuously happening. Second point already I told as a risk factor. In between opposite direction on pressure is getting while position changing time on the skin surface means also it will happen. So while seeing this type of bedbound or continuously pressure getting type patient, as a nurse or as a doctor, we need to assess something. First one, assess the patient pressure points. Now the patient body having no pressure sore, but we need to assess the pressure points. There is any color changes there or not, or brawny prominence, it's highlighting or not. We need to assess. Then, if already the patient having one wound means we need to assess the wound. If the patient is having pain or not, we need to assess. Then assess the location of the wound, where it is actually the wound is, which body part the wound is having. We need to assess. Then we need to measure the circumference of the wound and the depth of the wound. We need to assess. Then stage, according to the stage from stage 1 to stage 4, we need to assess. Then there is any exudate or not, is having any foul smell or infectious sign is there or not, we need to assess. Then we need to assess the tunneling. I have already told in stage 3 itself, the tunneling, have the chance to get tunneling. So we need to assess about the tunneling or not. Then we need to chart the finding. After the assessment, we need to chart the finding. So management, according to the stage wise, we need to do the management. So always, if the patient having on pressure sore or bed sore, if the patient is having this, first of all, we need to address about the pain. If the patient is reporting pain on that area, means we need to give the medicine for relieving the pain. Then only we need to move for the wound care. First stage means there is only the color change, not at all skin peeled off. So we need to teach the caregiver to change the position in between. Then on the color changed area, we can apply any means biolin or white petroleum jelly. We can advise to apply on that area. Then any incontinence history means do the needful for the management. Correctable the reason. Getting continuously contact with the fecal matter and the urine with the skin means getting the chance for the skin breakdown. So we need to correct it. Then stage 2, if we seeing the stage 2 means after cleaning with the normal saline, we can dress. Plain dressing needed. In between the biolin or petroleum jelly for a moisturizing effect, we can do as a application. Then in stage 3 and 4 or 5th stage, unstageable stage, in both 3 stages, if the stage itself, if having slough means already the thick or loosening slough means any surgical debridement needed means we need to do the surgical debridement. Then for the cleaning, we can use the normal saline for wound cleaning. Homemade saline also we can use. Not only it's from the pharmacy, the NS itself not at all needed. Homemade saline is also helpful for doing the for cleaning the wound. So there is any odor, malodor is there, or any infectious sign we noticing on assessment time means we can use the tab metrogel crushed form powder, metronidazole powder. We can use, mix it with any lubricant, white petroleum jelly or any liquid paraffin also we can use for mixing, and we can use it for the application. If any infectious sign is there, any malodor. One thing also we can do, we can give injection metrogel nebulization also for relieving the foul smell. If having very much foul smell and infectious sign is means after cleaning and during the procedure, we can give around 10 to 15 minutes injection metronidazole nebulization also. Remove the mask and using the nebulization that chamber or injection metrogel and nebulize around 10 to 15 minutes before applying the dressing pack. Then not only the surgical debridement, we can use debridase ointment also for dressing as a part of the chemical debridement procedure. Then mega heal ointment also we can use from third or fourth stage, means we can use the mega heal ointment for promoting the good granulation tissue. Whenever the granulation tissue totally it's in around stage 2, up to the stage 2 area, it's very much covered, means then the plain dressing only it's needed, or the over granulation will occur. So for avoiding the bad smell or foul smell, we need to avoid or need to manage, means we can use the charcoal pieces under the bed or inside the room corners. We can use it. It will absorb the bad odors. So it's act as an antioxidant. Then while cleaning the wound, we need to avoid the usage of any iodine or any hydrogen peroxide, such type of solutions we need to avoid for cleaning these type of wounds. Then any surgical debridement or maybe the lengthy tunneling is there, means also the surgery consultation is needed. If we feeling during the assessment time also, surgery consultation we need to do and do the management. Then last one is the negative pressure wound therapy, NPWT. This negative pressure wound therapy is mainly we using for suctioning the highly exudate, and it will promote the wound healing also. It's actually the normal suction apparatus only on minimal pressure. We maintaining negative pressure. We using the normal suction cath only. The tip it will place just after placing one layer of the pad on the wound. Then only we placing the suction cath tip. Then we again securely adhesive dressing also we will provide. In between, we do the negative. We just on the suction apparatus, the wound will get the negative pressure. From the wound, the exudate also will come out, and the blood supply also will improve on that area. So it will help the wound healing faster. So already I told homemade saline can use for the wound dressing. So normal saline, in homemade saline, how we preparing means 500 ml of water, take it and add 1 teaspoon of normal salt. Boil it, cool it, and keep it in a clean covered container. Can use this prepared normal saline, can use for the cleaning the wound. So here one thing we need to keep in mind, these wounds are all not at all sterile. This is not at all sterile, it's a clean wound only. So this saline we can call it as a clean saline only. Then for as a dressing pack, normally we using in hospital side, and if the patient and families are affordable means also, they will get the gauze pieces or sterile pads they can buy from outside. But long term, if the patient getting the dressing, the family is not affordable to buy these items, means they can make cotton, old cotton saris or dhotis. They can take, cut it into square pieces. In between the cotton pieces, they can keep a thickness a layer of gauze, as like gauze. This old cotton saris or dhoti pieces, they can steam it in idli maker, like that vessel. They can steam around half to 1 hour. Thoroughly after getting steam, they can keep it in a clean container. So while applying time, can apply Vaseline or liquid paraffin also. So it can easily, while removing time, it's very easily, the cotton pieces will not sticky with the wound. So we need to avoid the sticky appearance of the in between the wound and the gauze pieces or these cotton pieces, because if continuously sticking means also it will cause the pain for the patient on the wound. Then how we can prevent the bed sore? First on position change only. In every 2 to 3 hours, mainly for the bedbound patient, we need to change the position. So we need to educate the family members also need to change the position 2 to 3 hours, mainly bedbound patient. Then if the patient is continuously in wheelchair or in a sitting position means if the patient have upper body strength, their hand having the adequate strength means every 15 to 20 minutes, they need to, with support of their hand, they need to give pressure on the hand rest and just change the position because they need to upward the body parts. So the lower extremity and the sacral region, buttocks region, every part will get the relieving of the pressure for few seconds. They can count it as from 1, 2, 3, 4 up to 10, up to how much they possible they need to hold. They need to upward by applying pressure on the handrest of the wheelchair by using their both hands. So like that they can do as a like position change. Then if the incontinence, fecal or bowel or bladder incontinence, if having means we need to manage, catheterization is needed means we need to do. Then even the patient is continuously in diaper means also continuously wetting means periodical changing of the catheter or diaper or any pad they are changing means also periodically need to change. So that's how we can avoid the continuously contacting of the fecal matter and the urine with the skin. Then any special surfaces like air mattress or water mattress. Then if even one thing we need to keep in mind and one thing we need to explain to the family, even if the patient is on the air mattress or on the water mattress also, they need to change the position. Every 2 to 3 hours, they need to change the position. So these special surfaces will reduce the chance for getting the pressure sore. Not at all completely avoiding the or completely prevent the bed sore. It will reduce the chance for the pressure sore. So we need to, even if on the air mattress or the water mattress, need to change the position every 2 to 3 hours. Then proper nutrition and hydration, and actively if the patient is possible means active exercise or otherwise passively by the family members need to do the exercise. At least for the joints, for avoiding the contraction, need to do the exercise also for the patient. Then massage as a part of the skin care, skin massage also can do by using the liquid paraffin or white petroleum jelly. With the help of that can do the massage. Then while making the bed time, wrinkle free bed only need to do for the patient. So it will avoid the in between the color change of the skin or redness of the skin we can prevent. Then proper nail care also. Importance of the nail care also we need to explain to the patient family. So even if the patient having a lengthy nail, the patient is unknowingly or accidentally scratching on other body parts means also it will chance for the peeling of the skin. So we need to explain about that to the patient and the family. Then this prevention technique, we can call it as a S-skin, double SKIN. So how it will explain us? First one, yes, supporting surface. Already I told we can provide the or we can educate the family to lie down the patient on the airbed or the waterbed, but need to change the position every 2 hourly. Then second one is the skin inspection. Regular inspection, mainly the pressure prone areas, we need to inspect there is any color change or not. So earlier signs itself, if we treating or we managing means we can avoid the continuity of the pressure sore in stage 2, 3, 4 like that. Then third one, keep moving, position change only. Every 2 hourly need to change the position, keep moving. Then incontinence. Already I told bowel and bladder incontinence means the management need to do as per the situation. Last one is the N, nutrition. Proper nutritious food and the hydration level need to maintain for the patient. So this one is the prevention technique. Then mainly we need to engage the patient and family about in for preventing the pressure sore, or even if the patient is having wound means also, we need to involve patient and family in pressure sore prevention. So if the patient have the upper body strength, or if the patient can support the caregiver to change the position, means patient need to do, then only we can reduce the caregiver fatigue. Continuously fully support need to give by the caregiver, means caregiver fatigue will increase. So we need to explain about the importance of changing of the position to the patient also and the family also. Then by together only we can prevent the pressure ulcer. Then need to make a contract of care in between the patient and the family, same as like already I told. Then we need to ensure us like we do together to prevent pressure ulcer. That feeling the patient and family need to get. Then patient information leaflets, importance of the position changing, what are all the things need to do for preventing the pressure sore. In their language, we need to explain as like leaflets we can issue. This one is an example for the leaflet. This in a Malayalam language only. Here we providing this type of the leaflets. Here, how which are all the position in supine position, lateral position, which are all the pressure prone areas. These pressure prone areas we need to avoid. So what are all the comfortable devices as like pillows? How often need to change the position? In every position changing time, what are all the comfortable devices we need to provide for keeping comfortable for the patient? So adequate steps in their language, this in our mother tongue, Malayalam language. These type of leaflets we can make it and issue to the family. So that's why we can prevent the pressure sore. So now we can see on video how the position changes in every position. So I hope you are all understood about the pressure sore. So now we moving to second type of wound, fungating wound or cancer wound. So this one is a picture of a fungating wound. Actually, it's a primary or secondary malignant growth only in the skin, which has ulcerated and difficult to heal. It's a non-healing wound only, non-healing ulcer. The term fungating actually looks like proliferative growth, nodular fungus or cauliflower shape only. This type of wound can see. So actually, one nodule is forming while we moving to the pathophysiology, developing on a non-tender skin nodule, small nodules only. Primarily, we can see. Then after that, the enlargement of the nodules will happen. Due to the enlargement of the nodules, it will compressing or it will disrupting due to the compression, and it will disturb the flowing of the capillaries and the lymph vessel that flow. It will disrupt. Due to the disruption, altered coagulation or or bleeding, as like disorganized circulation. Due to the disorganized circulation, due to the in between the blood clot formation or due to the extreme bleeding, the tissue becoming hypoxic. Adequate oxygen supply will not get, and due to the hypoxic and gradually becoming necrotic, that tissue will forming as a after breaking down the nodules, the skin layer, it can see as like this fungating wound, cauliflower shaped wound. So this one is the Marjolin's ulcer. Marjolin's ulcer is, it's also a malignancy, type of malignancy only. Mainly if the patient is having a chronic wound for a long time, it's that much old wound, that chronic wound having some malignant changes, it will occur on the wound itself. So this is a type of malignancy of the skin only. It's old burn scar area, any pressure, prolonged pressure ulcer, then any venous leg ulcer. In this ulcer itself, the wound, this type of Marjolin's ulcer will happen. Pathophysiology, appearance of a mass inside the wound itself. Then onset of the patient will feel, suddenly patient will feel pain on that wound. Not previously, maybe the pain will not be there in this same wound. Suddenly the wound will develop. Then change of the character of the wound. Then volume of exudate. Any exudate is coming means also that discharge from the wound, that volume, appearance, maybe the smell it will change. Then as per the biopsy of the wound only, we can found it out it as a Marjolin's wound, or any malignant changes happened or not. So we can continue in the fungating type of this type of wound. Mainly the problem, 4 type of problems will happen in this such wound in patients which are having this type of wound. First one, physical, psychological, social, and spiritual. 4 aspects patient will affect about the wound. So first one, physical. Physically, this type of wound having severe pain. Patient may will feel pain. Then foul smell, malodor will happen. Then bleeding, altered circulation system. So maybe a large bleeding will happen. Then exudate, that much oozing out, or that much exudate. Volume of exudate also will increase day by day. Then itching, nearby or surrounding the wound area also, or inside the wound itself, patient may will feel the itchiness. Then maybe the any maggots formation also, there is a chance in that wound. Then if the patient having this type of fungating wound, mainly suppose consider this type of wound in the buccal area, CA buccal mucosa, this type of fungating wound on the face means it will affect the communication. Patient can't communicate or can't speak out the words, or otherwise patient can't face others for the communication. Then when we moving to the psychological factors, it will alter the body image. The one large cauliflower type, one huge wound on the body part, so it will alter the body image. Then sexual life also will disturb due to the pain and due to the alteration of the body image. Then the foul smell and exudate, it will affect. Then denial and fear. Patient will feel about fear. Next day by day, the wound size is increasing. So they have the tension and fear about next day and in future how the wound will become. So that fear and depression and anxiety about the wound. Then shame, feeling shame and guilty also. That guilt also patient will feel as like psychologically. Then social. In social life, these patients will maybe knowing by self only, patient will becoming inside the family in isolated state, or the family members will isolate the patient. So we'll feel the family isolation, and in society also, social isolation also patient will feel. Then fear of or social stigma. Patient itself maybe feel this stigma. It will not operate in the social any society. Then fear of contagion also. Any communication of disease from me to others, or maybe the society itself they may feel from the patient will get the chance for communicating this type of to others. Then family also will affect. Inside only one room, maybe some patients being in a one room, The family members very rarely only will enter into the room due to the main concern, the foul smell, exudate, and the appearance of the wound only. Then effect on sexual relationship and marital life also will affect as a social part. Then spiritual, maybe some in these type of wound, if patient is having, means the patients cannot involve in the religious activities or religious rites they can't involve. Maybe the patient will feel this is happen according to the punishment from the God. God only punish me. Then fear of death. These are all the things happening in the spiritual aspect. Then for this wound also, we need to assess something, wound location. Then it's mainly the exposing area means adequate dressing or dressing materials we can use for covering. We need to avoid the public attention on that area. So we need to assess the wound location. Then wound appearance, highly exudate is coming or not, that how the wound appear, we need to check. Then surrounding skin also, that highly exudate is coming and getting contact with the surrounding skin continuously means it will affect the nature of the skin on the surrounding area. So surrounding skin also we need to assess and we need to be clean. Then any complication in any bleeding, the chance is there or not, we need to assess. Then according to the assessment, we need to manage the wound. First one is the palliation factor only. First of all, we need to address about the pain. We need to reduce the pain. We need to manage the pain. Then we need to control the malodors or infectious sign is there, means we need to do the needful. Foul smell, for this wound also, for managing the foul smell, we can use the injection metronidazole nebulization we can use during the dressing time. Then exudate, highly exudate means also due to the infectious means any antibiotic, course of antibiotics is needed means also we can do. Periodical changing of the dressing thing also we can do for managing the exudate or wetting the dressing material. Then for minimize the bleeding, any measures needed to do means also we need to do for minimize the bleeding. So because we need to control the fear factor of the patient and the family. Then holistic care, total care. I already told 4 aspects of the distress of the patient. So holistic approach need to, in that only we need to manage this type of wound. Then empowering the patient, not only the patient and the family also to do the wound care, because this is a non-healing ulcer only. So while doing the wound dressing time, first one, we need to set in our mind and we need to explain to the family also. We need to maintain or improve the quality of life with the fungating wound through the symptom control only. So first of all, we need to act or we need to do everything in an empathetic care only we need to do. So we need to understand about the patient. We need to understand the situation. Then only we need to do the dressing and the management. Then before the wound dressing, we need to explain to the patient also or the family members, provide a thorough bath before the dressing. Then ensure that before dressing itself, patient have to take the analgesic medicine, whichever maybe the patient is getting means also. Before dressing, ensure patient is already took the analgesic medication. Then use normal saline for cleaning the wound. No other solution is not at all needed as like betadine or hydrogen peroxide. Only the normal saline only we can use. Before removing the old dressing, thorough wet. We need to soak it as a thoroughly with the saline. Then only we need to remove the old dressing pack. Otherwise, it will cause the bleeding, spotted bleeding or massive bleeding. It will occur, and along with that, patient will feel pain also. We need to avoid this situation. So adequate soaking with the normal saline. Then only we need to remove the old dressing pack. Then proper dressing also we need to do. Then for minimizing pain, if patient feeling deep pain on the wound, means aching, stabbing, or continuous type of pain, means the systemic analgesia, whichever may be, we need to give or adjust the dose if it needed, means also we need to do. Then superficially, the burning or pricking type of pain patient is feeling on the wound area, means local application of injection lidocaine or injection bupivacaine we can do. Before the dressing itself, around 10 to 15 minutes before wound dressing, also we can do this soakage with the lidocaine or bupivacaine, or after cleaning during the dressing pad applying time also we can, if suppose needed, means we can do the local application with the lidocaine or injection bupivacaine. So if the wound having the malodor, means daily cleaning and the periodical dressing pad change is mandatory for avoiding the malodor or control the malodor. Then if suppose having that much malodor, foul smell is having, means locally we can apply on the wound metronidazole powder form, tab metronidazole tablet, crushed powdered form we can apply after mixing it with the liquid paraffin or the biolin or petroleum jelly, white petroleum jelly. So IV metronidazole irrigation also helpful, and the nebulization also helpful for controlling the foul smell. Then any systemic antibiotics is needed, means according to the situation we can, if we needed to start, means we need to start and give. Then frequent changing of the dressing pad is very, very important. Then only we can control the malodor. Then no hydrogen peroxide or beta-like solution is not at all needed to do for cleaning the wound. Then if we need to control the bleeding, we need to first of all prevent the bleeding. That's why while removing the old dressing pad, thorough soakage with NS, then only by for just we remove the old dress, then only we can prevent the bleeding. Then apply, if suppose spotted bleeding is happening, supervision on the wound area, means apply normal pressure. So then along with that sucralfate powder also we can use for controlling the bleeding. Then if suppose the bleeding is increasing, means systemic like tranexamic acid we can use for locally also we can apply. Then systemic ethamsulate like things we can also use for controlling the bleeding. Then palliative radiation also, suppose it's needed for the controlling bleeding, means we can suggest the palliative radiation. Then along with that, during the bleeding time, for avoiding the fear factor of the patient and family, we can provide dark colored cloth also for avoiding the fear factor. Then role of cancer therapy, mainly this type of fungating wound. First one, radiotherapy only. Second one, cytotoxic chemotherapy. So in this cytotoxic chemotherapy, our main aim is to destroy, or we need to destruct that cancerous cells. Then hormone therapy, any surgical intervention is needed, means only we can suggest surgery, or otherwise we need to keep in mind this type of fungating wound. We can proper dressing and a proper maintenance only we can improve, or we can maintain the quality of the life only. Along with the wound only, up to the death, the patient need to live. So we need to keep it that in our mind. Then this one is the last condition in the fungating wound itself. Suppose on maggots condition it will occur. This maggots mainly happen open, exposed wound. Continuously, if the patient is exposing their wound with the open air itself, any flies is accidentally resting on the wound, laying egg, then only the maggots it will form inside the wound. So proper dressing, proper covering of the wound is very much important. That importance we need to explain to the patient and the family. So first of all, we need to prevent the maggots. So for the prevention, inside the room itself, we can educate them to use the mosquito nets or maintain personal and environmental hygiene is very, very important. Flies is continuously getting contact with nearby wound or nearby patient side we need to avoid such situations. So environmental hygiene also very important. Personal hygiene also important. Suppose if one wound we seeing with maggots means we can apply, not at all directly applying, just turpentine soaked gauze piece or pad. We can keep that piece on the entry point of the wound nearby that. So these maggots will feel the smell of the turpentine and it will naturally it will come out. So manually we can remove physically or manually we can remove one by one these maggots very slowly inside. If suppose inside the fungating wound itself some pocket formation or inside some tunneling, it's maybe will happen. Such areas without seeing the internal, we don't use arteries because there is a chance of bleeding. So it's a highly bleeding point maybe there inside the tunneling or pocket formed area. So if during this showing this turpentine swab the swab with the smell whichever the maggots is coming, that time just manually we will remove, then physically remove, then proper covering of the wound in all time, daily, periodically, as per the situation, as per the wound status, periodically we need to change. At least 2 times we need to do the dressing for this wound. Suppose more exudate and more foul smell is having means in between we need to change the position. Change the dressing, or otherwise at least 2 times we need to change the dressing pad and the proper cleaning and the proper removal of the maggots. Step by step only we can continuous process only we can we can completely remove all maggots from the wound. Along with that, same as like fungating wound, metronidazole injection, nebulization we can give during the cleaning time, irrigation we can give, then proper medication as per the wound status we can apply on the wound for the dressing.
Thank you very much, Sajan. This is, as I keep telling, like nursing care is equally or even more important at these type of situations. So once everyone is aware of it, then at least you will be able to get going from that. You can pick up what it is and then move forward from that. Stage by stage, you have given explanation on how it could be managed. And one important thing through this, through the presentation, I was thinking is, like you mentioned that isolation, no? Many people are scared that it's infectious and the odor and this using charcoal and things which are all available at home. They are all so many home remedies. And then even for the dressings, what you mentioned, we keep telling, and it's one important thing for all of you to be aware from the beginning, as he has mentioned, normal saline, which could be prepared at home. See, we also have to keep in mind the financial element of all the patients that we see. And in all this practice of the last few years, I've been doing this home dressing. We teach them, and especially when we do home visits, we go show them what can be done. And I think at present situation, most of the houses will have a rice cooker or something, which could be used very well. Rice cooker or a idli cooker at least will be there in most of the houses. So this could be done. And buying dressing on a regular basis, that will be one of the reasons why they're not changing the dressing. See, that is why we have to look into the causes. So they may say we are not changing dressing. If you then ask only, they'll say the cost element will come. So if you're going to give an alternative for that, they may say, oh, is that possible? So like awareness, teaching in all stages are important, and use of metronidazole tablet as powder form, no word to say. We have seen patients come with these, even these fungating type of wounds, with the dressing, they respond very well. There's a question in the chat box. Dose of injection metronidazole for NEBs. Go ahead, Sajan.
Actually, there is not considering about the dose. Normal injection metronidazole on the nebulization mask set on the chamber now. Inside the chamber, just pour 2 to 3 ml of injection metronidazole. As like same quantity, if we suppose giving a normal nebulization, how much quantity of whatever may be the things we taking, same quantity of injection metronidazole, we need to pour it and give the nebulization for 10 to 15 minutes. Our main aim is in the fungating wound or maybe in the pressure ulcer also, in between the tunneling or pocket formation is there. Without seeing the inside what is happening, without seeing inside the tunneling area, we put in the arteries and trying to clean it means chance for getting bleeding. One more thing also, foul smell from the internal tunneled area. Suppose thorough cleaning is not at all possible due to the bleeding chance. There is foul smell can manage. The infectious sign also we can manage. Then the highly exudate also continuously is coming from the. So if we giving the nebulization means as a fume state, this injection metronidazole content can reach up to the every single point point of the same wound. So it's very helpful. So don't think about the dose. The quantity only can keep in mind, 2 to 3 ml.
Exactly, that micro size is the important, because as Sajan mentioned, you're not able to, so that by nebulization, what happens, again, little bit of physics, that droplet size, it is so small, so that access is attained by that. So that is how the benefit is used. And here, as he said, no, that nebulization, that much amount, what it can take, only you put in that. And similarly for metronidazole tablets, we encourage them in different forms. Like sometimes we ask them to put like 50, 100 tablets, powder them in a small blender or something like that and keep, and then make the paste with, as he mentioned, with petroleum jelly. So they are all very useful. Anaerobic element is covered. So, and there are plenty of studies and papers which has proven the benefit of this. Anything else anybody wants to ask? Because this is a very common thing which all of you will be facing in different forms. It could be a chronic ulcer, it could be ulceration or something due to immobilization. And again, I need not go into the cause. You can name differential diagnosis and causes limitless. So this is something which is very, very common. And so being aware of it and also teaching the carer the importance of their hygiene also. Simple thing what I would like to add on here is just hand hygiene. To teach them, tell them what is the importance of them washing their hands just with soap and water before they do the dressing. And do the same thing after they do the dressing also. The first one is for whose benefit, and I need not go in. So basically, teaching them these things. No, first one is to make sure that the patient gets the benefit, and the last one is to make sure that the carer gets the benefit also. And simple soap water wash has been proven to be the best. That's the proven one in infection control, rather than using any other antiseptic, all that. The soap water wash, and then teach them how they should do hand washing. So because see, the carer, either the kith and kin or whoever does that at home, has to be very careful, because we have to, whenever palliative care, from the definition we say, We have to look after the patient, and the carer is also looking after the carer and teaching them and raising awareness is part of our duty too. So those things, and then similarly, any body fluids. I think all of you do practice, no, that 5 points of care where you wash your hands and things whenever they change a catheter bag or any other fluid. So all those things, no, just by putting a picture or something in the place where it is done. So whenever they come to have a consultation, they see that, or you try, the nurse can give a little bit of information on that. So main thing is that raising awareness. If you tell that to one patient and the attender, we may be thinking one person and attender, it will go a long way. She will convey it to her friends and family, and then that will go. If it's a small village, she may volunteer to do help someone. So like that, no, we may not know how far it goes. So doing these little things will be very, very helpful. Yeah, if there are no more questions, we can go on to the case discussion, Shri Priya.
Dr. Daniel?
Am I audible?
Yes.
Yes.
Go
ahead.
Good evening, everyone. Myself, Dr. Daniel, will be presenting a case on wound management. So this is a case about an 88-year-old male whose diagnosis was infected bed sore on sacral region, uncontrolled type 2 diabetes mellitus, hypertension, and dyslipidemia. Presenting complaints, there was infected bed sore on left buttock, foul smelling discharge and pain in and around the bed sore. Next. History of illness, history of RT 10 years back, and he was treated in a government hospital, diagnosed as quadriparesis, history of long-standing DM, hypertension, and dyslipidemia. Bed sore developed 2 years back, and he was on treatment from local hospital. Since last 1 week, foul smelling discharge and pain on the wound side was noted and was referred for further management. There was also decreased food intake and generalized tiredness. On examination, he was conscious and oriented, poorly built. Temperature was normal, pulse rate 88. BP and respiratory rate was normal. All systems were within normal limits. Local examination showed a superficial bed sore on right sacral region, stage 2, and deep bed sore with cavity on left side, stage 4. Local rise of temperature and tenderness was there, and foul smelling discharge was present. Treatment and significant investigation. The main treatment was change of position every 2 hourly, and airbed was given. Slough cutting was done under local anesthesia. Wound cleaning using normal saline and dressing was done. Injection cephalosporin plus sulbactam, 1.5 gram, 12th hourly was given. Regular insulin according to GRBS. Ringer lactate if he was feeling tired. Tab Zincovit, Stilos, that is Stilosol, tab vitamin C, losartan, and Atova were given. Investigations, pus culture and sensitivity yielded protease species. Random blood sugar was 265 mg per dl. Hemoglobin was 9 and total count was 18,000. Psychosocial aspects. He was from a low socioeconomic status. Family included son, daughter-in-law, and 3 grandchildren. His wife died few years back. Son is the sole breadwinner of the family and is a manual laborer with daily wages. Son and daughter-in-law took care of the patient, and they live in a government-provided house. Medications on discharge. Antibiotic tab Ziplox was given for 5 days. Pantop, Zincovit, Stilos, vitamin Z, oral hypoglycemic agents. Tab Glimi was given. Tab Losartan, Atorvastatin. Cleaning and dressing using normal saline was advised to do at a local hospital. Air or waterbed was advised, and changing position every 2 hourly, and was asked to review if needed. The main concerns were financial constraints and the foul-smelling wound of the patient. Patient needed help for every day-to-day activities, and there was continuous pain in and around the wound site. Summary: the 88-year-old bedridden elderly with foul-smelling discharge and pain from the pressure sore site. Points to be discussed: stages of bed sore, prevention of bed sore, pain management, wound management, and problems faced by this patient, and role of palliative care for this patient. Thank you.
Thank you. Chipriya, maybe we can come out of this slide and then so that everyone could participate in. And Dr. Daniel, like Sajan, you want to take her through, because the first few points, that's what we have had in our session today. What is that you would have done different, or what is that you've done in for the first three discussion points you mentioned, Dr. Dania?
First, madam, I didn't get your question.
No. See, the first few points in your discussion were like staging. You yourself had mentioned, no? It was stage 2 at some parts, and it was stage 4 at some levels. So first is assessing, and that element you have mentioned in your presentation, and then management and things. Did you do all as per what was mentioned in our session, or would you do anything differently to after the session?
Madam, I would rather have a personal talk with the patient. What his main concern is. Like, since he was bedridden, he needed help. So rather than just the medical aspect,
Correct.
he needed more of a,
counseling
emotional attachment. Since his wife also passed away, his son and daughter-in-law was looking after him. He needed some sort of,
loneliness.
connection.
He was feeling void, that there was no one there for him.
Yes,
everyone has their own work to do and activities to do, and they have their life going, and there's no one for me. That's a common thing, isn't it? So
yes,
those are the 4 elements mentioned by Brother Sajan, all 4 elements to be looked into. No, so was this patient in your hospital itself, or?
No, madam. This hospital, I mean, this patient came during my house urgency period. So I had a case regarding us. I didn't have any case on wound
Okay, no
management,
problem,
so
no
I had
problem.
to.
See, that's all. So exactly, no, but the case is so appropriate for the topic of the day. That is the most important thing. So that's what. So before knowing about it, how it was managed, and after having the session today, how is that differently you would do? That is the main element of this whole program, isn't it?
Yes, madam.
How you would have done is one part of it. So now, as you said, you will look into the pain as a whole. So for the pain, then coming like assessment management is what you have said. And then for the pain management as such, what was given, was that adequate for him?
No, madam. It wasn't adequate for him.
And from that point of view, I would like to add on what was mentioned by Sajan, that we call it as preempt, like you give the pain relief medications an hour ahead, or 40 minutes to an hour ahead, before doing any dressing or anything like that. That is very, very important, because see, it shouldn't give them a feeling of, they even develop fear for dressing change, or anticipating the pain. Oh, when they start doing this, it will hurt. When they move me, it will hurt. When they take the dressing, it will hurt. Yes, see, everywhere inside that person, that human element is there. So that is what has to be taken care of. As mentioned, you soak the dressing. Every element of what you all heard today is important. You anticipate the dressing that you're going to do. So give either their own regular pain medication or give an additional dose so that they are pain-free at the time of dressing. Don't make the dressing element as something they fear, they hate, they don't want. It's not to be made like that. Okay, so that is something important. So you do that, and then that is give something for pain before, and then during the procedure, what all you're going to do, how you do it. Everything is equally important. So if you do like this, and then accordingly, pain, then assess. If you give something ahead and then do this dressing and see how the patient feels, and then take it from there. So is this dose enough, or you do it the same way, or do I have to increase, decrease next time when I do it? So all those factors also have to be taken into consideration. And then, and you do the dressing and appropriate. No, in this patient, if you see the case, the culture sensitivity was positive, so you need some antibiotic. His white cell count was 18,000. So every element, if you look into, you have had the session, put all elements, what you learn from it into this, and his management will definitely be better off. So that is the important thing, to look into things like that, whether we have considered everything and what type, and then teaching this patient and the family what are the ways that they could do things at home itself. Like you saw, the saline can be made at home, the dressing materials can be made at home, and then teaching the family, like the video that you saw, how they do the sheets, and then changing position, that every 2 hours change does wonders.
And the charcoal also, ma'am, for the...
Yeah, charcoal is very, very important. That's why I said in the beginning, charcoal is so important. And then teaching one more thing with the family, that if it is non-infective, non-contagious, either the patient can be like, if patient could be transferred to a wheelchair, come to the other room where the whole other family are there, come and spend 5 minutes, 10 minutes, so that the person also has a chat with the rest of the family. Maybe when, so something like that on a regular basis, morning once, evening once. So, okay, twice not possible. When the family is free, everyone goes to work. Okay, evening, they're all free. 10 minutes, they're being around. So these are things which can be taught to them. And if you tell all these, oh, can this be done? So all of you know, only when you start practicing, you will see how much benefit you gain out of it. And also, as you go along, you can see, and it's worth, as I always say, it's worth visiting centers who do active palliative care to know how it is done and what are the benefits that it gives. So that's something very, very important to be aware of. Sajan, you just add on whatever you want to add on.
Thank you, ma'am. Actually, almost points covered by you, ma'am. Thank you very much. First of all, suppose this patient I am seeing means also, as earlier told by Radha ma'am, we need to manage the pain. No need to make the patient about us like fear of wound dressing process. So we need to manage the pain. Proper medication, any analgesic medication, suppose patient need to take before the wound dressing itself, we need to ensure the patient is taken or not. Any topically, any pain medicine, we need to apply on the wound before the dressing. Suppose we needed to apply means also we need to apply. While removing the old dressing pattern also, thorough soaking with NS is very, very important. By that also we can manage the pain and the bleeding chance. from the wound. Then after removing during the dressing time, first of all, in your case, I think one wound is stage 4 and one wound is stage 2. Stage 4 means maybe the bone or muscle layer is exposed, maybe. In such condition, the depth of wound daily or at least once in 3 days, we need to check the circumference and we need to check the depth of the wound also. So then we can understand how the wound healing development is there or not. Then during the dressing time, if that 4th stage wound having any slough, means any debridement manually, suppose we need to, means also we can do. Otherwise, like debridase ointment, that also we can use for solve the debridate, sloughs. So then mega heal ointment we can use for improving the granulation tissue in such type of wound. In stage 2 wound means we can, after thorough cleaning with the normal saline, just we can advise them to put the thick biol also in that wound. Just only we need to maintain the moisturizing effect on the wound and in between the wound and the dressing packing. No other medication also. It's suppose needed on medication means also tea-bagged ointment we can suggest for application. Plain dressing only needed for the stage 2 wound means. For the biolin, it's only needed. Suppose if it needed means only can suggest the tea-bagged application for the wound. So in this manner we can advise them to do or continue the dressing in their home setting also. Then financial constraint, the reporting about the wound dressing material purchasing time means we can educate them to make as like homemade saline and substitute for the gauze. They can use the cotton cloth pieces. They can sterile, make it as not as and we can tell it as a sterile for making clean. They can steam it in idli maker or a pressure cooker. They can, after steaming it, they can keep it in a clean vessel and periodically they can use for the changing the dressing. So like that they can do. Then we can address the what are all the problems facing by the patient. Already if they're having the foul smell means patient will refuse to take food also. With inside the room that much foul smell, patient only will feel that much foul smell in 24 hours continuously. How the patient can take food? Even family members also just closing their nose only, they will enter into the room and giving food to the patient. Patient itself selfly feeling why I need to take this food, or otherwise what importance, what benefit I'm going to get in this situation. My wound is worsening, this much of foul smell, my own family will isolating me, or otherwise they just turning their face and come in front of me for giving food, or otherwise in just attending me. So such situation we need to address and do the needful for address the need and do the needful for managing this foul smell, pain and everything. Then as a role of a palliative care nurse or palliative care doctor, our main role is to address the symptoms, address the concern and address the difficulties, both the family, both the patient and the family. In our palliative care aspect, we say not only the patient and along with that the family also. Caregiver burden also we need to address in this situation. Not only about the patient. Caregiver also that much suffering due to these issues. So we need to understand do the management and do any suppose on counseling or just listening about their difficulties also. We can do so much wonders for us, like the management for the patient and the family.
See, reiterating, see, both of us are like parrots singing the same song, okay? Because it's important. That's why we are singing the same song. So again and again, be have the empathy, humane element in it, find out, and then look into each part of it. That's the important thing. See, generally, no, all of you are doctors, okay? Most of it you all know. Little important things. Adding on, that is the important element in it, okay? So fine tuning, I would say. And then on top of that, you mix both together, and then the benefit comes for the patient. What is that? We are looking at palliative care to reach everyone, because it is not big rocket science. It's just the interest, enthusiasm to get it across. So that's the important thing. So I think overall that the important thing in this, the physical, psychological, and then that SS, the mnemonic, SSKIN, that is very, very important, because you tell all that, the all of you will see, even like if it is picked up early, treating is so easy. If you pick it up at stage 1 or 2, you don't go to 3, 4, 5. So healing becomes easy, patient benefits. So no need to go into finding ways of managing the worst stages if it's possible. So that is the important thing. Okay, there's no more questions in the chat box. So in that case, I will pass it on to Shripriya then. Thank you, Brother Sajan.
Thank you, ma'am. Thank you.
Thank you, Brother Sajan, because I personally know that you have had a very busy day in our IP setting. And after that, you came running here to throw light on this very, very important topic, I would say again. Because whatever Sajan Brother said, even I was like, being a non-medical person, I was reflecting on that the patient will not be able to have food when there is foul smell, of course. So I would put it in a non-medical way that even as common black tea becomes special if you add at least ginger to it. So that is how I would compare things. Like that makes a difference. A black tea then becomes the magical ginger tea, which might provide you with instant relief from some ailments. So thank you, Brother Sajan, for walking us through this wonderful session. And I believe that all the participants would have got at least one new message from this session. Thank you, Dr. Dania, especially for bringing in this very appropriate case and presenting that. Thank you, every participant, for joining, and with the promise that we'll be meeting again in the next session with another different topic and another eminent faculty. This is Sri Priya, along with Brother Sajan and Dr. Radha Venkatesh, signing off from the Tipsy Hub. See you in the next session. Till then, everyone, take care, keep spreading happiness. Bye-bye.
Thank you.
Thank you, everyone. Thank you.